I invite Dr. Prasida VK, Assistant Professor, Government Medical College, Thrissur, with multiple publications to her credit.
Welcome, Prasida. Today's topic is DAS and CPR. Okay.
Hello, sir. Meeting after a long time. So thank you to I'll start by thanking the organizers for this wonderful opportunity. And I enjoyed being a delegate here for this one well-organized academic feast. So coming to the updates, we'll first go into the DAS guidelines, the Difficult Airway Society guidelines of 2000. I have included only the updates because of the short time. So the highlights will be on the emphasis on the successful first attempt. Differing from the previous guidelines where you were managing failures, the emphasis is now on a successful first intubation attempt and airway assessment and planning properly. The concept of per-oxygenation, the concept of physiologically difficult airway, and rapid sequence induction and intubation, point-of-care ultrasound, and cricothyroidotomy revisions, and mainly focusing on the human factors. So coming to the airway assessment, it has ideally to be performed before induction and identify difficulties in all steps from A to D, that is tracheal intubation, face mask ventilation, insertion of supraglottic airway device, and performing E-FONA. So this includes the history. Definitely they have pointed out a history of obstructive sleep apnea and a previous history of difficult airway. They hold highest points there. And in examination of the airway, the upper lip bite test has been found to be an accurate predictor. And visual inspection, palpation, or ultrasound in the extended neck position for the cricoid thyroid membrane should start with airway assessment. And the investigation suggested are point-of-care ultrasound, virtual endoscopy, and NACE endoscopy has been suggested because it is a very rapid, simple tool which is available in the OT. And awake video laryngoscopy for airway assessment, CT scan and three-dimensional printing has also been given. And I think after the previous talk, we can use AI also. And screening for physiologically difficult airway. So these are two simple criteria which is mentioned in the guidelines. That is the Haven criteria and the McCoca. Haven has been included in the pre-hospital setting because you can screen the airway with a simple tool. And in the critical care setting prior to intubating a patient also, you can include the scoring system, which can be even done by the nursing staff there. So coming to what are the strategies during your airway management. Everything should be pre-formulated. There should not be any confusions or planning on the spot. So, and you should always have, when you anticipate a severe difficulty in bag and mask ventilation, just like a bleeding airway, you can always go for a awake tracheal intubation, which the options will be flexible bronchoscope, video laryngoscope, or a tracheostomy. And the airway management should be included in the team briefing when you start the case. And special mention is that the anesthesia assistant should be well informed of your strategies. And all the equipments for delivering plan A to D should be available. And preparedness for high-risk out-of-hours airway management, or even in NORA, you should always have a senior input there. And a checklist for emergency intubation will be very helpful. And coming to monitors, continuous waveform capnography is recommended during all phases of airway management like bag and mask ventilation, starting from bag and mask ventilation. And the ASA standard monitoring should be applied with, you can add on inspired and expired oxygen concentration to that. And quantitative neuromuscular monitoring is ideal to ensure your quality of intubation. And enable audible alarms of the pulse oximeter so that you don't get task fixated. And regarding drugs, the neuromuscular blockers must be routinely used for difficult airways. And saxomethanium can be used at a dose of 1.5 milligram per kg, but consider the side effects of the drug. And a new drug which we commonly use is rocuronium for emergency intubation. So it has an advantage of reversibility with Sugammadex. But always remember that Sugammadex reverses only the motor function, and it doesn't doesn't protect your airway actually, because you are left with an unmanageable airway still, and you have an added disadvantages of laryngospasm, anaphylaxis, and aspiration. Sugammadex rocuronium combination is reported to have the highest anaphylaxis. Coming to the techniques of pre-oxygenation, the recommendations for pre-oxygenation is always try to use a head-up position whenever feasible. And the interfaces that are advised are face masks with or without CPAP, that is a positive pressure, and high-flow nasal oxygen and non-invasive ventilation. Then per-oxygenation techniques means apneic oxygenation as well as during your attempts of intubation, airway securing. You can use a nasal cannula of high flow or low flow. And HFNO has been specially recommended for anatomical and physiologically difficult airways. And always, while using an HFNO, to be effective, you should ensure the patency of your upper airway. And whenever you find the mask ventilation difficult, if you are using an HFNO or a nasal cannula, just remove the HFNO or cannula to improve the seal of the mask. And HFNO should not be considered as a rescue device for failed bag and mask ventilation. So coming to the Plan A, the major difference in Plan A comes with the video laryngoscope, which was recommended previously also, but it should be considered for first-line use whenever possible when you're anticipating a difficult airway. And the availability of VLS and its competency to use it must be sought after. And with hyperangulated video laryngoscopes, you can use stillets, bougies, or even flexible bronchoscope, that making it a hybrid intubation technique. 3+1 attempt, that was even in the previous guideline, and you have to verify the success of intubation using a 2-point check, that is continuous waveform capnography, and they have suggested a visual confirmation whenever possible of the tube passing the vocal cords. So regarding mask ventilation, the important predictors shown are obstructive sleep apnea, history of radiation therapy, high BMI, increased neck circumference, and a malleability class 3 and 4, and a male sex. And while doing a mask ventilation, there is a definite clarity in the subtle changes even happening during your induction procedure. That is, subtle changes during bag and mask ventilation, like an increasing airway pressure, loss of tidal volume, or a loss of seal, and increasing effort on the part of the operator should always be indicating a progressive airway difficulty, and it should be clarified there itself. And the difficult bag and mask ventilation should be confirmed verbally to the team, and the help should be sought, and the strategies must be adjusted. And they suggest, when you are using a two-handed technique, they suggest a VE-handed technique. It is more better seal than a CE two-handed technique. And they also included simple scoring systems like Lim and Nielsen for effective bag and mask ventilation, where you can correlate with your ETCO2 starting from a good square wave pattern at grade A to an absent pattern at grade D. And regarding the Plan B, the initial transition to Plan B has been maintained, but there is emphasis on stop, think, and communicate part there. And after 3 attempts of, in between, they suggested maximum of 3 attempts of supraglottic airway insertion for oxygenation, but in between the attempts, always remember to change the size, either the size of the supraglottic airway or the type or the technique used for insertion. You can modify your techniques in between rather than repeatedly putting it for 3 times. So modified, and if the decision to stop and think, the most wise decision or the most safe option will be to always awaken the patient. They have mentioned that specifically, whenever possible, to awaken the patient. And when you're deciding to proceed with the supraglottic airway, you maximize the success of ventilation with the supraglottic airway by using an NG tube, decompressing the stomach. You adjust the cuff pressure of the device, optimal head and neck positioning, and the use of neuromuscular blockade. And when you are attempting intubation through the SAD, only 1 attempt at intubation, that too using an FOB, not a blind intubation, and that too done by an expert. And at this stage, they remind you that the front of neck access is always better than an emergency access there. And Plan C, the final attempt at face mask ventilation, the original protocol has been maintained, and they add on that when you are attempting a final rescue, you ensure that the neuromuscular block is adequate, ensure adequate optimal patient positioning, use airway edgings like oropharyngeal, nasopharyngeal airway, or even both of them, and always early use of a four-handed technique, that is a 2% technique, and always ensure the depth of anesthesia at this stage. And moving on to the e-fauna, or the original plan has been retained. The only change is that ensure maximal neck extension while performing an e-fauna, always remember that, and give a full dose of muscle relaxant before even starting the procedure. And vertical skin incision is now preferred, and you can extend it up to 8 centimeters. And a transverse incision may be considered only if you have used an ultrasound to mark the cricothyroid membrane or it is very anatomically palpable. And failure of e-fauna, it's bound to happen, and you have to keep on attempting it. They have recommended that. And if it is unsuccessful, always consider extending the incision more, dissection of the wound, and position change of the patient if it is not optimal, operator change even, and smaller endotracheal tube than the 6 millimeter original ET tube. And they have included psychological support for the team who have been in an e-fauna. And coming to rapid sequence induction and intubation, the specifics have been almost the same, where they have added on with the high flow oxygen for pre-oxygenation whenever possible, especially if you are having a cesarean section with a high BMI, you can go for a high flow oxygenation technique. And video laryngoscope, the other advantage is that when you are giving a cricoid pressure, the ergonomics will be better for the assistant also. If you are not visualizing, you need not verbalize that to release the cricoid or alter the position, the person can do so by himself. So the shared view is an advantage, extra advantage with the video laryngoscope. And coming to the concept of physiologically difficult airway, physiological alterations in a patient puts him at risk of cardiorespiratory events or complications during tracheal intubation and subsequent positive pressure ventilation. So it may be a physiological age group like pregnancy, old age, or a pediatric population, or it may be pathophysiological because of hypoxia, metabolic acidosis, hypotension, sepsis, or RV failure as in a critically ill patient. So improve the oxygenation technique in this group of patients, either with a pre-oxygenation technique with a positive pressure is mostly recommended, that is use of a CPAP device or a pressure support with an NIV. And per-oxygenation technique you can always prefer for high flow nasal oxygen. And in this group of patients, ensure the hemodynamic stability by appropriate fluid resuscitation and management, use of vasopressors earlier, and you select a good choice of induction agent. And avoid multiple attempts and make the intubation at the first attempt maximally successful. So coming to the guidelines in obesity, you prefer awake tracheal intubation in this group of population. And they should always be pre-oxygenated in the 30-degree head-up position, and consider performing the airway management in other situations, especially inside the OT. Do not attempt airway maneuvers outside the OT, and use high-flow nasal oxygen for per-oxygenation, and early use. If you're failing the face mask or during induction, you cannot intubate, you go for the supraglottic airway much earlier, considering rather than the other population. And regarding point of care ultrasound, it is used for airway assessment. Before the procedure, before induction itself, you can have a localization of the cricoid cartilage and the cricothyroid membrane, and it can be marked. And identification and marking is not only beneficial for a sleep technique, but also for awake, because it forms a plan B of your awake tracheal intubation techniques. And it should be ideally done with the neck extended, because that is the position by how we are attempting the e-fauna. And the risk of aspiration by the gastric residual volume can also suggest your airway strategies. It can also modify your airway strategies. And coming to the human factors and non-technical skills, the core component, it is now a core component in all the DAS guidelines. So these are the common principles. Priming means you prepare for the e-fauna right from your failure of plan A to C, not wait for the technique till you fail the C technique. And transitioning means you're recognizing failure at each step and moving fast towards the next step. Calling for help is not dependent on the seniority or the role of the person calling. And the decision to call, whom to call, how to call should be made at the team briefing itself, and that task should be assigned to somebody other than the airway assistant. And the airway assistant should be trained technically in technical as well as in non-technical aspects of airway management. He should be able to provide a continuous waveform capnography working, and he should have situational and time awareness. Whenever possible, he should have assertive communication skills that can be used. Different tools are there, and calling for help should have a low threshold. To summarize, the DAS guidelines say that the maximize success at the first attempt is prioritized now. Video laryngoscopy for first-line use and continuous oxygenation, that is the para-oxygenation, should be adapted wherever. Physiologically difficult airway should be considered. And E-Fauna technique for a standardized vertical incision and human factors to be remembered in each step of a difficult airway. Now we'll move on to the guidelines in the 2025 AHA guidelines. So as mentioned before, the uniform, there is a single chain of survival rather than the 4 chains of survival in the previous guidelines for in-hospital and out-of-hospital cardiac arrest for separately for adult and pediatric patients. Now it has a uniform chain of survival. If you observe the chain of survival closely, you get see that there is a 6-link chain, and missing from that is a part of prevention is missing, and also they have included in the part of the high quality CPR image of the lungs, considering the importance of ventilation during CPR. And it has a 7-link newborn chain of survival also. And the highlights will be a special chapter or special mention on ethics and opioid overdosage algorithm and public access to naloxone and a foreign body airway obstruction algorithm and training for children more than 12 years to use to undergo CPR training and AED use. For neonatal resuscitation, there is a delayed cord clamping and there is cord milking for non-vigorous, non-active term and late preterm infants, and cord milking not above less than 28 weeks. And the oxygen concentrations have been specifically mentioned, the peak inflation pressures during ventilation, and BLS for intubation in newborn resuscitation has been introduced, and LMA for ventilation above 34 weeks, and a TP's resuscitator for preterm resuscitation has also been suggested. In the pediatric life support, the most highlight is the elimination of the 2-finger compression. You have to follow only the thumb encircling the chest as well as the heel of one hand technique, and minimizing the perishock poses in pediatrics. And regarding foreign body airway obstruction, back blows with 5 abdominal thrust alternating has been suggested. In pediatric advanced life support, early epinephrine, whether shockable or if it is shockable after 2 shocks, and otherwise as early as possible. And these are the diastolic BP targets during to guide CPR in pediatrics. ETCO2 can be used as a monitor for quality, but no specific cutoff values should be used as an indicator to end your resuscitation. And post-cardiac arrest, they have suggested a continuous arterial monitoring with systolic BP and mean arterial above 10 percentile for age. And for neuroprognostication in pediatrics, no single data entry point should be used. Continuous ECG for 72 hours is recommended, EEG. And in adult, there is a new algorithm for foreign body airway obstruction. So this is the algorithm for foreign body airway obstruction, followed by 5 back blows and 5 abdominal thrust in both adults and children. And late pregnancy and infants, the abdominal thrust has been replaced with chest thrust. And always the recommendation is to remove foreign bodies before giving bag and mask ventilation. And in life support, there is an addition of cardioversion of atrial fibrillation and atrial flutter, with starting at 200 joules biphasic because of the greater shock success, lesser cumulative energy required, and shorter anesthetic duration. The vector change and double sequential defibrillation, which are not recommended for routine practice. Head-up CPR as part of a bundle has recommended to be used only in designed trial settings, and whenever in adults, intravenous access has to be preferred over intraosseous. And regarding polymorphic ventricular tachycardia, the previous guidelines used to suggest many medical modalities. So, just one more minute. The immediate defibrillation is the treatment of choice now recommended. And post-cardiac arrest care, the targeted temperature management is a minimum of 36 hours recommended. And these are the values for temperature control. Mean arterial pressure target is 65. And they have introduced 2 new diagnostic techniques, that is a head-to-pelvis CT and a point-of-care ultrasound in the post-cardiac arrest care. Invasive neuromonitoring, no advices have been given, recommendations on which is more effective. And myoclonus has to be managed only after EEG analysis, and neuroprognostication and healthcare professional burnout has also been. Pregnancy has been extensively covered in the previous topics. There are no new recommendations there. And opioid is assisting the respiration with bag and mask, and the access to naloxone for all rescuers, trained laypersons and public. And hypothermia, these are the recommendations. Hyperkalemia, the medical treatment for hyperkalemia like calcium bicarbonate has not been proven efficiency in cardiac arrest, and it is suggested to continue with your CPR techniques rather than continuing with. Then high consequent respiratory pathogen like in COVID, PP is found to be effective and is protective for the rescuers. And extracorporeal life support in reversible situations. Anil sir has elaborated on the role in amniotic fluid embolism. And left ventricular assist device, when the perfusion is difficult to assess, these are the guidelines they suggest. And to summarize, the main updates are a single chain of survival, a new foreign body airway algorithm, new opioid overdose algorithm, and elimination of two-finger compression in pediatrics. And defibrillation, the double sequential defibrillation is to be avoided. And cardioversion energy in AF and flutter has been revised to 200 joules. Public access to naloxone and the targeted temperature management in 36 hours has been recommended. So these are my references. And thank you.
Congratulations, Prasida. You have put two broad topics in a single capsule. Congratulations.
Thank you, ma'am, for this wonderful session.